If you're watching this video, you or someone close to you has sustained a significant ACL injury or ACL tear. Now, compared to the old days, ACL tears are not really career-ending injuries anymore. They're just kind of career obstacles, let's say. We have a lot of surgical tools and a lot of treatment options to get people back to playing sports that they love. Now, I'll never go and say that you have to have your ACL fixed because, what we do is not really heart surgery or brain surgery. It's not life or death. You can live your life quite easily without an ACL. However, if you do want to engage in a lot of cutting and pivoting activities, sports such as soccer, basketball, lacrosse, field hockey, anything where you're not running in a direct straight line, then we strongly urge you and recommend that you have your ACL fixed so you don't have continuous kind of giving way and pivoting type episodes when you're playing your sports. Now, the way we go about fixing your ACL isn't really like repairing the tissue like we do in a lot of other injuries. Now, there is some new scientific evidence suggesting that in the near future, we'll be able to repair the ACL and keep your old ACL. But nowadays, we haven't really reached that threshold yet. So what we typically do is what's called an ACL reconstruction. And this is where we remove the old ACL and we make a new one, basically. Now, there are two main ways that you can reconstruct an ACL. One is by using the patient's own tissue, which is called autograft. And the other main option is by using tissue from someone else. So that's called allograft. Now, autograft has its advantages because it's your own tissue. We think it heals pretty strongly and pretty well. And it gives you the best chance of not having the ACL get injured again when you return back to sports. The downside of autograft tissue is that it's your own tissue. So you kind of have to rob Peter to pay Paul. And it could be associated with a little bit more pain in the early postoperative period. And the surgery can take a little bit longer because we actually have to harvest the graft before we put it back into your knee. Now, when we think of allograft tissue, there's a lot of perks. Mainly, we just take the tissue from the freezer, we thaw it, and we slap it into your knee. So there's less surgery you have to go through. There's less recovery. It's less painful. It's quicker from a surgical standpoint. But some of the negative effects is that it is somebody else's tissue. And we think that it doesn't heal and incorporate as quickly into your knee the way your own tissue would. And for young, active, healthy people under the age of 30, we do know that there's a higher failure rate with ACL allograft tissue compared to autograft tissue. So for all intents and purposes, the patients that I treat were pretty much mostly kids under the age of 18. We strongly urge and recommend not only that they have their ACL reconstructed, but they use their own tissue called autograft. Now, when you think about autograft, there's lots of different places in the knee that you can take someone's tissue from. The main place that I like to take it from is their patellar tendon, which is we take a little sliver of tendon in the front of the knee, and we take bone on either end, a little bone from the kneecap and a little bone from the shin bone, and we take what's called a patellar tendon bone construct. Before I came to DuPont, I used to work with some of the Philadelphia professional teams like the Eagles and the Sixers, the Flyers, the Phillies. When I was training at Jefferson, and when those guys tore their ACLs, we pretty much always used patellar tendon autograft. So I feel like that's the best tissue for my athletes and the young kids, if that's what they're mostly putting in professional athletes. Now, you can also use hamstring tissue, which is from the soft tendons behind the knee, and that works well. There are many centers where they use that predominantly. It doesn't have the rigid bone fixation the way patellar tendon autograft does, but it is a viable option. We typically use that for people who are what we call skeletally immature, or people who are still growing, because we don't want to cut through their bony growth plates and potentially, disrupt their growth. So we would actually use hamstring autograft in those young kids who are still growing. Now, there are also surgeons out there that use quadriceps tendon autograft, which is a sliver of quadriceps tendon tissue with a little bit of bone from the kneecap. I don't use that so much. I tend to default to the patellar tendon autograft, but the quadriceps tendon is an option as well. When I do this procedure, it's mostly arthroscopic. So we take a camera and we put it inside the knee. We look around at all the cartilage structures. We look at the meniscus pads, and we deal with any injury or trauma that's happened to the meniscus pads as well. If we have to do a repair with sutures or just trim some of it out, we'll do it all in the same sitting. The surgery typically takes about 2 hours. It's a same day procedure. You'll come and go the same day. You'll go home with an ice machine. We'll make sure that you have and you know how to use crutches. You'll have a brace on your knee, and we'll send you home with pain medications, usually a narcotic like Percocet or Vicodin, an anti-inflammatory, something really strong that's called Toradol or Ketorolac. It's like Motrin or Advil, but it's much, much stronger, and it's prescription strength. And we also send you home with something called Zofran in case your belly gets nauseous or upset, either from the anesthesia or from the narcotic pain medications. One of the cool things that we do with your prescription pain medications is we have a program that's called Meds to Beds. So what I do is I take your medications and I prescribe them electronically to the pharmacy in the main hospital, which is on the first floor. And as long as everything's okay with your insurance, our pharmacy will fill that prescription for you and actually deliver it to you in the waiting area while you're waiting for your child's surgery. And that's very neat because then you don't have to fumble with paper prescriptions that you can lose or get wet or something like that and have to bother stopping on the way home with a groggy child or a child that's in pain, and then go into a physical pharmacy to fill and wait for your prescriptions. What we do is we kind of take care of all of that for you so you can get delivered a nice bag of medications while you're waiting for the procedure to end. And then as soon as your child is done and your child is awake, then you all can go home with your meds. And it just makes things a lot more convenient and practical for you. So a lot of people ask, well, when can I go back to school after an ACL reconstruction? I typically do surgeries on Tuesdays and Fridays. So if you were to have surgery on a Tuesday, we would think that you'd be ready to get back to school by Friday or like 3 days after that. And if you had surgery on a Friday, we think that you'd be ready to go back to school the following Tuesday. Another thing people ask me about is, well, when can I drive after surgery? So for those of you that are old enough to drive and know how to drive, if it's your left leg that you're having surgery on, you can probably drive pretty quickly after surgery, as long as you've recovered from anesthesia and you're not taking any more of the narcotic pain pills. Then you can drive probably the next day. If it's your right leg that you've had surgery on and you drive an automatic car, you're going to want to wait till you have full range of motion post-operatively before you can drive. And that's not really just for your knee, but it's mostly for the overall safety of yourself and other people on the road. You want to make sure that you can grab the steering wheel and slam on the brakes or speed up if you need to. And you can't have really sluggish range of motion and be able to do that. So I'd recommend that whatever point it is that you get full painless range of motion, that's usually around 3 to 4 weeks after surgery for that right knee, that I would recommend going ahead to drive. People often ask me, well, when can I put weight on my leg? Well, you're going to be numb after surgery. They're going to do a nerve block that numbs up your leg, that keeps you comfortable for about 8 hours or so when you leave. So your leg may feel kind of weird, but you're going to be in a brace and you are going to have crutches. So we say that you can put a very small amount of weight on your leg, even the day of surgery when you get home, as long as you feel stable on your crutches. We call that toe touch or flat foot weight bearing, where it's basically just the weight of your leg on the ground, not really your body weight on your leg on the ground. We have you do that for about a week. And if all goes well, when you come back at that first post-operative visit, when we check your range of motion and look at your wounds and see how comfortable you are. If all's going well, then we usually let you fully weight bear on your leg at that time. So when you go home, we usually will see you back in 1 week's time, at which point we'll start physical therapy, we'll do a wound check, we'll answer any other questions that you may have, and we'll see you at several times after the procedure, usually at around 3 weeks, 6 weeks, 3 months, 6 months, and 9 months. Oftentimes, we may need you to do physical therapy prior to the surgery also. One of the big issues with this surgery is that you can get knee stiffness afterwards. So we want to make sure that you have full and free, painless range of motion prior to the surgery. So most kids, when they have this injury, we usually send them to physical therapy for about 3 or 4 weeks to help them regain their motion prior to surgery. And once they have full range of motion, that's when we know that they're ready for surgery. So that's something that we may ask you to do. Now, the big question is, well, when can I go back to sports and when can I play? So kids recover pretty well, and you'll be up and about on crutches and going back to school pretty quickly and walking around. But in terms of cutting and pivoting sports, we usually fully clear you at around 9 months. So when I did my work with the professional athletes, specifically the NFL athletes, most of those folks went back at around 9.8 or 10 months after surgery. And these are guys in their early 20s who are in the best shape of their lives, getting physical therapy daily, working with top-notch therapists and athletic trainers. And it still took them on average 10 months to get back to sports. So when we say on average, that means sometimes it may take even longer. So we entertain fully clearing people back at around the 9-month mark. And what we do to make sure that you are ready is we do an objective functional ACL test where you'll work with one of our athletic trainers and they'll have you run and jump and do different things in our gym. And we'll measure both of your legs, the strength and agility in both of your legs. And we'll make sure that your surgical leg is about 90% as strong as the well leg. And when you get to that point, then we feel pretty safe and confident that you should be able to return back to sports without too much difficulty. Now, sometimes kids take this functional ACL test at the 9-month mark and they don't pass. And that does happen. And it's okay. It just means they may need a little bit more time to get stronger and to develop their agility. We'll usually have them continue therapy and exercises for another 4 to 6 weeks and then get retested. Whenever you do get cleared and you get advised to go back to sports, oftentimes kids ask if they need a brace. In the old days, in the beginning of my practice when I first started, I mandated that every kid had a brace for at least a year when they went back to sports. Now, with new research and my experience, I realized that it's not completely necessary. And we don't have any hard and fast research that suggests that by wearing this brace, you're not going to tear your ACL again. So I do offer it to kids who are interested in it. They want a little bit of an extra psychological advantage and something that just kind of makes them feel stronger, makes them feel more confident. There's nothing wrong with using it, but I don't mandate that kids have to use it. In terms of the logistics, when you do come into the office for a visit, I'll give you the information for my secretary and then my administrative staff. They'll be able to, find a date and a time that works well for you all's schedule at a time when we know that your knee will be quote unquote ready for surgery. And they'll go ahead and get you scheduled accordingly. And we want to make sure that you do this at a time that's most convenient for you. You want to make sure that if there's a mom or dad or a guardian that's around to take care of the child when they're recovering. You want to make sure that the child doesn't have, SAT tests or the prom or some big trip coming up. You can pick a date and a time that's most convenient for you all. I typically do surgeries on Tuesdays and every other Friday. And again, my administrative staff will work with you to find a time that works the best and is most convenient for your schedule. So hopefully this, little primer video was informative and allowed you to get a glimpse into how I treat ACL tears. Obviously, when you come and see me in the office, we'll go over things a bit more thoroughly and I'll examine your child and we'll answer any other last minute questions that you may have.